Welcome to Artificial Intelligence Techniques in Digital Histopathology. I am Hussam, your teaching assistant and the presenter in this course. In this lecture series, we will establish the essential groundwork for understanding how AI integrates into histopathology from tissue to algorithm. Today's focus is threefold: what pathology and histopathology are, how biological specimens are prepared from diagnosis, and the pivotal role of microscopy in clinical decision-making. This foundational knowledge is important not only for interpreting digitized slides, but for designing, validating, and deploying robust AI systems in real-world diagnostic workflows. By the end of this lecture, you will be able to distinguish between pathology and histopathology, trace a specimen through the full pre-analytical pipeline from biopsy to reporting, and explain how optical principles underpin digital slide acquisition, thereby setting the stage for AI integration. So let's begin. Pathology is a cornerstone discipline of modern medicine. It's defined as the scientific study of disease, encompassing etiology, which refers to the causes and the mechanisms, and also the structural and functional consequences of disease on organs and tissues. Practically, pathologists examine specimens, including tissues, cells, and body fluids, to render the diagnosis, guide therapy, and predict the clinical outcome. Importantly, pathology is not merely descriptive, it's analytical and integrative, synthesizing morphological, molecular, and clinical data to inform patient care. If you look to the figure on the right, you will find that the diagnostic tests is split into pathology and radiology, and our path will be in the pathology branch. Below the pathology branch, there are clinical pathology, anatomical pathology, and we will be in this sub-branch where we are going to study the histopathology. So histopathology is a specialized subfield of pathology, distinguished by its exclusive reliance on microscopic examination of tissue, and we use something called specimens. Specimens are typically obtained via biopsy, surgical resection, or autopsy. Histopathologists interpret the morphological alternations such as nuclear atypial loss of polarity, stromal invasion, or inflammatory patterns to differentiate between the benign and malignant processes, infectious agents, or autoimmune phenomena. Because many diagnoses, particularly malignancies, are confirmed histologically, histopathology remains the diagnostic gold standard across oncology, dermatology, and beyond. So now we understand the difference between pathology and histopathology. Again, pathology is a discipline of modern medicine that studies the causes, mechanisms, and effects of the structure, function of organs and tissues. And inside the pathology, there is a sub-branch or a specific branch called histopathology, where here we focus on the microscopic examination of the tissues, aiming to diagnose the diseases. In pathology, we use microscopes, and the microscope is a central instrument of histopathological practice. Its function is to magnify structures beyond the resolution of the human eye, typically below 200 micrometers, rendering them to a detailed view. In pathology, microscopes are not merely magnifying tools, they are diagnostic interfaces. While modern digital pathology is shifting toward virtual microscopy, the optical principles and performance metrics established by the conventional microscopy remain foundational for image quality, algorithm training, and interpretative validity in AI systems. As you see on the figure on the right, the human eye looks at a part called eyepiece, and there is a base where you can find some light is emitted below the specimen. So here we put the object that we need to magnify, or the specimen, and some sorts of microscopes emit light below the specimen so that we can simply magnify and be able to see what's inside this specimen or object. So as mentioned, there are different types of microscopes. The first of them is light microscope, and this remains the workhorse of diagnostic histopathology among its variants, and those variants can be bright field microscopy, and this one is used nearly for all routine specimens or slides, and it produces high contrast images by illuminating the specimen from below. Second is phase contrast microscope, and this enhances the contrast in transparent unstained specimens, particularly valuable in cytology, where we can study the urine and effusion samples, where staining may be deferred. Third one is called dark field microscope, and here the dark field microscope creates contrast by illuminating specimens from the side, causing the light to scatter off the specimen and appear bright against a background, as you see here in this figure. The last variant is fluorescein microscope, and it uses fluorescein to visualize specific molecules or structures within cells, and it often uses fluorescent dyes or proteins. So simply to distinguish between them, in the bright field microscope, there will be a light, that's why there is a white background here, and this will be the specimen. For the dark field, there is some sort of contrast, so the background will appear dark and the specimen will appear like that. And for the phase contrast, we can ignore the staining and apply some sort of contrast of transparent specimens so that the contrast and effect of this microscope can visualize the specimen. The second type of microscopes is called electron microscopes, and it's unlike light microscopes, as here electron microscope transcends the resolution limits of light microscopy by utilizing electron beams instead of photons, and there are two principal types that can serve the pathology. The first is called transmission electron microscopes, or TEM, and it passes electrons through ultrasonic sections about 50 to 100 nanometers, revealing the subcellular ultrastructure such as mitochondrial cristae and nuclear pores. The TEM remains essential in renal pathology and in diagnosing certain soft tissue tumors with characteristic organelles. A second type is called scanning electron microscope, or SEM, and it scans the specimen surface, generating a detailed 3D topographical reconstructions, and it's useful in studying microbial adhesion or surface morphology of implants. Though limited in routine diagnostics due to cost and preparation complexity, the EM provides irreplaceable insights in select clinical and research contexts. After understanding and getting familiar with the different types of microscopes, including light and electron microscopes, let's move to the components of a microscope. And here we will be talking about the compound microscope, or let's say the standard microscope that combines and contains two lenses. The first is called objective lens, and the second called eyepiece or ocular lens. And these are the two essential components of a microscope. Both of them contribute to the overall magnification of the specimen being viewed. The first is called the objective lens, and it's located near the specimen, and it collects light and forms a primary real inverted image. And there are different magnification levels of the objective lens, such as 4x, 10x, 40x, and 100x. And by increasing the magnification level, you will get and obtain finer details. The second one is called eyepiece or ocular lens, and it's typically 10x in magnification, but it can include other magnifications such as 5x and 15x, and it magnifies the intermediate image for the observer. While ocular magnification is standardized, its quality such as field flatness and chromatic correction significantly impacts viewing comfort and diagnostic accuracy during prolonged examinations. So we have objective lens, where it's located here close to the specimen, and the eyepiece or ocular lens, which is located here close to the observer. And to calculate the total magnification, we can get the product of the objective and ocular magnifications. For example, a 40x objective paired with a 10x eyepiece can get and obtain 400x total magnification. And this calculated simply by multiplying the magnification of the objective and the magnification of the eyepiece. However, clinicians must be cautioned. Magnification alone doesn't guarantee diagnostic utility. Without a suitable resolution, contrast, and proper illumination, excessive magnifications lead to empty magnification, a larger but in a blurry way. Hence, optimal microscopy balances between the magnification with optical fidelity. We mentioned that there are magnification objective and magnification for the eyepiece. To obtain those values, we have two models. The first is called linear or simple approach model, and the second is called exact model. Let's go through each of them. The first is linear or simple approach, and here we calculate the magnification of the objective and eyepiece in terms of the focal length and length of the tube. This is the eyepiece close to the observer, and this is the objective length close to the specimen, and there is a tube. So the length of the tube will be denoted by L, and the focal length of the objective, which is denoted by FO, is located here. So if this distance is 5, so FO will be 2.5, and the focal length of the eyepiece is the other part of the lens, which is located here. And the formula for obtaining the magnification of the objective is dividing the length of the tube by the focal length of the objective. And to obtain the magnification of the eyepiece, we divide 25, which is the least distance of distinct vision, by the focal length of the eyepiece, which is denoted by FE. So both of them are simple and linear. And don't forget that we have a negative value here. But to calculate the total magnification, we take the absolute values of both of them. So let's assume this example. If we have a length of the tube with 30 centimeters, a focal length of the objective given by 40 millimeters, the focal length of the eyepiece is 50, so we can obtain the magnification of the objective by multiplying 30 by 10 to obtain the value in millimeters, divided by 40, so we obtain a value of 7.5. And for the magnification of the eyepiece, you will do the same and obtain a value of 5. So now we have two values, 7.5 and 5. So the total magnification value will be 7.5 multiplied by 5, which will be 37.5 times. This will be our overall or total magnification. This approximation is useful for introductory teaching and quick estimation, but it assumes ideal lens placement and ignores any lens thickness and separation. As we shall see next, the exact approach reveals non-negligible deviations. So the second approach is called exact approach, and this approach is a more precise formulation, and it accounts for the finite distances between the focal points of the objective and the eyepiece. Again, we have the three parameters, the length and the focal length of the objective and the focal length of the eyepiece. So we calculate the magnification of the objective by subtracting the focal length of the objective and the eyepiece from the length divided by the focal length of the objective. Then we can calculate the magnification of the eyepiece, and we have two options, relaxed and straight. The relaxed viewing assumes that the image at infinity, and it's a standard for prolonged use, and strained viewing, which assumes that the image at 25 centimeters and accommodated to the eye, where here we add just +1 or extra 1 is added to the strained compared to the relaxed. And this distinction is critical in optical design and calibration of microscopy systems, where sensor placement mimics either condition. So let's move to an example. Assume similar values so we can get the magnification of the objective in the exact approach by multiplying 30 by 10 to get them into millimeters, subtract 40 and 50, divide by 40, we can obtain an exact value of 5.25. And let's assume here we are going to use the relaxed, so we will obtain a value of 5. So the total magnification will be 5.25 multiplied by 5, which is 26.25 times. Now let's consolidate with a clinically relevant example, a standard microscope with L value of 160 millimeters FO is 4 millimeters, which is 40x magnification of the objective. FE is 10 millimeters, which is around 25x magnification of the eyepiece. And we need to calculate the magnification of the objective lens and the eyepiece and the total magnification of the microscope for the relaxed and strained views, for the approximate and exact approaches. So for the relaxed and approximate, we will use the linear formulas. For the magnification of the objective, we divide the value of L by the value of FO, which is 160 by 4, refers to 40 magnification. And the magnification of the eyepiece is 25 multiplied by 10, because 25 is in centimeters, divided by 10 refers to 25. So the total magnification will be 40 multiplied by 25 will be 1000 times. If we need to obtain the strained with the approximate or the linear approach, simply the values will be similar, but here we will add an extra one to the magnification of the eyepiece. So instead of 25, it will be 26. So 40 multiplied by 26 will be 1040 times. Now let's move to the exact approach using relaxed and strained. Again, we mentioned that the difference between strained and relaxed is an extra one added to the magnification of the eyepiece. To obtain the magnification of the objective, we subtract 160 minus 4 minus 10 divided by 4. Then we can obtain 36.5. And for the magnification of the eyepiece, it will be a similar value to here. It will be 25, and here will be 26 by adding the extra one. So the magnification in the exact approach will be around 900, and for the strained approach will be around 950 times. And as you notice, there is a gap or a difference between the approximate or linear and the exact approaches, close to 100 times in magnification. That's why most of the manufacturers apply effective magnification, not only the theoretical one. After understanding the meaning of a microscope and how to obtain the magnification levels with respect to the eyepiece and objective, we need to know what we are going to magnify. This part is called a specimen, and a specimen in histopathology is any biological sample submitted for microscopic evaluation, ranging from millimeter scale core biopsies to multi-organ resections. Its integrity is paramount. A specimen is not merely tissue, but a diagnostic artifact shaped by pre-analytical variables such as fixation delay, and errors in this stage, such as crushing, drying, or labeling, cannot be corrected downstream and may lead to false negatives or indeterminate and incorrect diagnosis. Thus, specimen quality is the first and often most overlooked determinant of diagnostic accuracy. We can obtain these specimens using different methods such as biopsies, surgical resections, and cytology procedures. Again, we are aiming to diagnose the diseases, identify any abnormalities, and determine the nature of pathological changes within the tissue. There is a certain workflow which is tightly orchestrated and split into 9-step pipeline, starting from fresh tissue collection and ending by archiving, passing through fixation, processing, sectioning, staining, cover slipping, microscopic examination, interpretation, and reporting. And we are going to discuss each step individually. And here, each phase is interdependent, and a failure at any step propagates forward. Understanding this pipeline is essential, not only for troubleshooting poor image quality, but also for designing robust pre-processing pipelines that can mitigate staining, variability, folding, and sectioning artifacts. Let's begin with the first step, which is fresh tissue collection. And collection method dictates downstream handling. First, biopsy, where the tissue samples are collected using different techniques depending on the location and nature of the suspected pathology. This can include needle biopsies, such as this figure, excisional biopsies, and endoscopic biopsies. And these are different types of the biopsy. And again, the target here is to collect a fresh tissue. The biopsy is minimally invasive, but samples are small and prone to sampling error. That's why the orientation is critical. Second, surgical resection. Those specimens are obtained during surgical procedures, and the specimens may require specific handling to preserve their integrity. And then comes the autopsy. It's systematic, multi-organ sampling, and the aim here is to collect samples of tissue from deceased individuals to determine the cause of death or underlying diseases. So here we have three branches to collect fresh tissues or specimens, whether using biopsy, surgery, or autopsy. Once collected, and here we are referring to the specimens, the second phase comes, which is called fixation. And fixation is preservation in action. And here we need to preserve the specimen to prevent any decay and maintain its structure. And fixation stabilizes the cellular structures and prevents autolysis or self-digestion. And during fixation, we use fixatives, which are the solutions or the materials that perform the fixation. Formalin is the most used fixative due to its ability to cross-link proteins and stabilize cellular structures. There are different types of other fixatives such as ethanol and Zinker solution, and some of the fixatives are used for specific purposes. The third part is the fixation type, and there is a duration of fixation, and it varies depending on the size and the type of tissue, but typically varies from several hours to overnight. After fixation, the tissue undergoes processing to prepare it for embedding into paraffin wax, and it includes dehydration into alcohol, clearing in xylene or other clearing agents, and infiltration with melted paraffin wax. So we begin with dehydration. So tissues are dehydrated in a series of alcohol solutions of increasing concentrations, aiming to remove water molecules and prepare them for infiltration with paraffin wax. Then clearing happens after dehydration, where the tissues are cleared in a solvent aiming to remove alcohol, which is a dehydrating agent, and make the tissue transparent, like xylene or alternative clearing agents. Infiltration, which is a third step, where the tissues are immersed in melted paraffin wax, allows the wax to penetrate and replace the clearing agent, and here we are providing support for subsequent sectioning. Wound processing manifests as soft blocks for incomplete infiltration or brittle sections or over dehydration, and in digital slides, those artifacts appear as uneven stains or faults. After processing, the microtomy starts in place. So the paraffin embedded tissue block is mounted on a microtome, a device that looks like this device, where it's sliced into thin slices called sections of uniform thickness. And microtomy demands skill and precision. And the section thickness, which are the thin slices, the output of the microtomy, varies depending on the specific requirements of the examination, but commonly ranges from 4 to 5 micrometers. So sections with 3 to 5 micrometer thick are standard. Too thin means below 2 micrometers. And here you can see something like nuclei appear fragmented, and too thick, more than 7 micrometers, where you can see overlapping cells in the specimen. Then there is something called ribboning, where multiple sequential sections may be cut simultaneously to create a ribbon of tissue sections for efficient processing. And in short, here we collect consecutive sections, and this can facilitate the architectural reconstruction. And here we have two types of sectioning: serial sectioning and serial interrupted sectioning. Serial sectioning is a procedure of collecting and mounting sections on a slide in the sequential order in which they were cut on the microtome. A ribbon here refers to the sequence of connected sections pulled from the microtome, while in serial interrupted sectioning is a procedure of collecting multiple ribbons of sections, each at a different area within the tissue block, such as cutting ribbons every 200 micrometers. And this method of sectioning is ideal for capturing multiple areas within a tissue on a single slide. To understand that, let's look to those two figures. So for the serial sections, which is the figure on the left, we have a ribbon from section 1 to section 6 and another ribbon from section 7 to section 12. By applying serial sections, simply we will take sequential ordering. So section 1, 2, and 3 will be mounted on the first slide, 4, 5, 6 will be mounted on the second slide, and the same for the other ribbon, 7, 8, 9 for a third slide, and 10, 11, and 12 for a fourth slide if we need it. And here we can apply different stains or coloring to different slides. But for serial interrupted sections, simply we get the first ribbon, which is sequential from 1 to 6. Then we skip around 200 micrometers and cut another sequential ribbon, and then skip another 200 micrometers and cut another ribbon. And in each slide, we take a specific section from each ribbon. So in the first slide, we will take section 1 from ribbon 1, section 7 from ribbon 2, section 13 from ribbon 3 on the same slide. And again, the benefit of doing that approach is that we are capturing multiple areas or regions on the same slide. And for slide 2, we will take the next sections 2, 8, and 14, and the same for the third slide and fourth slide. Now we can stain each of those slides in different stains and capture a view of different regions on the same slide. We mentioned here that we are applying stains or coloring. So what is the meaning of that? The tissue sections are stained, and this target and highlight specific structures or components within the slide. And staining transforms the tissue into diagnostically informative images. There are different types of stains, where hematoxylin and eosine H&E stain is the most common method, and it can be considered as a standard stain, and it highlights cellular structures. In H&E, it stains nuclei blue and purple with hematoxylin, and cytoplasm and extracellular structures pink with eosine. It can be considered cheaper than other types of or special stains. Some special stains can be used to visualize specific tissue, components, or pathological features, such as BES for carbohydrates or Mathon's trichrome for collagen fibers. Also, there is IHC or immunohistochemistry, and it involves using antibodies to detect specific proteins within tissue sectioning, and it aids in the diagnosis of tumors and other diseases such as breast cancer. And there are many other stains, but the most standard or the standard one is called hematoxylin and eosine or H&E. On the left figure, there is the epithelia classification cartoon figure, and epithelium is one of the 4 primary tissues in the human body. Epithelia are composed of closely aggregated cells that cover most body surfaces, cavities, and tubes. These include the outer surface of the body, which is the skin, tracts traversing the body, which is the gastrointestinal tract, dead-end tracts that have opening of the body surface, such as the respiratory, and ducts that open into those tracts, which are the exocrine glands. The functions of epithelia are numerous, and a single epithelium may have several functions. The most important of those include physical protection and selective transport, which is diffusion, absorption, and secretion. And the figure on the right is a specimen, which is stained in hematoxylin and eosine. And as we mentioned, the hematoxylin stains the nuclei in blue-purple colors, and eosine stains the basic structures such as cytoplasm and extracellular structures in pink. So as you see here from the figure, you can determine that this is a nuclei and this is a cytoplasm or extracellular structure. By understanding both of them, referring to epithelial classification and H&E stains, you can simply understand or get familiar with the pathology slides or these specimens, aiming to later use them in the artificial intelligence pipeline. Here, This is a figure of a simple squamous epithelia, where simply by targeting the pinkish colors, we can say this is a cytoplasm or extracellular structures. So this will be the cytoplasm, and this will be the nuclei or nucleus, because this is in the blue-purple color. And here we mentioned the simple squamous epithelia, because if you look, there's a structure of simple squamous epithelia, as you see in the cartoon figure here. And for simple columnar epithelia, you find here a structure like columns, like that. And this refers to a simple columnar, like that. And it's not pseudostratified because this structure aligns in the same shape, or the columns are identical, like here and here and here. And simply, you can say that is the extracellular structure or the cytoplasm, and this will be the nucleus. And you can use this information later with artificial intelligence pipeline, aiming to classify between if there are irrelevant or something wrong with this nuclei by classifying it into benign or malignant. So some features that we may obtain and inject into our pipeline is like the width and the height of the column in the columnar epithelia, or the shape of the nuclei, or the morphology of it, and we are going to discuss that during our course. And there is a figure of endothelium, and we said that because it looks like a vessel or a tube, where here we find red blood cells, and the nuclei or nucleus are covered in blue-purple, and the cytoplasm in pinkish color. And the figure on the right is from a study where they aim to segment the nuclei from the different histopathology images, including images for the colon, liver, bone, and the prostate, and comparing the different approaches together, aiming to emphasize the importance of their approach. For staining, a cover slip is then placed over the tissue section using a mounting media to preserve the slide or the specimen and provide optical clarity. And here, the mounting operation secures the section and optimizes the optical performance. The mounting media can be watery or organic-based material, and simply we get the specimen and the slide and put the cover slip on it. But before that, we put the mounting media and then put the cover slip, as you see here, and it will be the final version. Bubbles, uneven thickness, or crystallization degrade the image quality in both visual and digital microscope. And whole slide scanners require flat, bubble-free cover slips to maintain focus across gigapixel images. And failure here induces the z-axis drift, complicating the 3D reconstruction. So this step is important to obtain bubble-free cover-slipped specimens. Then the final three phases comes, including microscopic examination, interpretation and reporting, and archiving. Examination begins at lower power 4x to 10x to assess the tissue architecture, then shifts to higher power 40x to 100x or more for nuclear detail, such as the mitotic activity. And here, the pathologists and or histotechnologists analyze the tissue morphologically, cellular features, and any abnormalities present, and they evaluate that, aiming to make a diagnosis. Then findings are synthesized into a structured pathology report, often using CAP protocols, which directly informs the clinical decisions. And the pathology reports include a description of the tissue, any abnormalities identified, and the pathologist's decision and diagnosis or interpretation. It can also include additional information such as tumor grade, stage, and prognostic factors. This report can then be communicated to the healthcare provider responsible for the patient's care. Slides and blocks are then archived increasingly as whole slide images for digital consultation and research. Critically, every step mentioned and discussed introduces systematic variability, and in AI development, this variability are not noise, they are domain shifts. So understanding this pipeline is just not optional. It's the foundation of building models that generalize across labs, scanners, and staining protocols. So in this lecture, we have covered the meaning of pathology and histopathology and knew that the histopathology is a sub-branch or subfield of pathology, which covers the diagnosis and knowing the disease under microscopes. Then we shifted to know what is the meaning of a microscope and the different types of it. Then we went through the different equations to understand how to calculate the magnification values using the linear and exact approach. After that, we went through the different steps of the specimen creation in histopathology, from gathering the tissue until archiving, passing through the different subphases, and we concluded that we need to understand that carefully, aiming to reflect that into our AI pipeline. In lecture 2, we will begin the digital journey, starting with the whole slide imaging and data fundamentals.